Tēnā koutou katoa, and welcome to tonight's Wet and Windy Wednesday webinar. It's wet in Northland. This evening we are joined by the lovely Linda Grady, a clinical nurse specialist for critical care at Southern District Health Board. She also shares her time working as a clinical tutor at Otago Medical School and as a professional teaching fellow for Otago University. Linda was one of the founding members of Dunedin Hospital's Tracheostomy Response Team, TRT. And just about this time last year, Linda was recognised by the Otago Nursing Excellence Awards for her contributions to leadership. She has also completed postgraduate studies in the fields of critical care, aeromedical retrieval, advanced health assessment, leadership and management, and completed a clinical master's in education. So now we all know where to go if we want help with our assignments.
Thanks, Catherine. After that introduction, I feel a bit of a fraud. I don't feel like any of those people that you introduced me to tonight. It's something to do with age, I think, and the fact that it's the end of a very long day. So thank you for all joining me and talking about this. Now, I used Florence and the Machine on my first slide. I think it would be really, really wonderful if we had our lungs on the outside of our body. It would make breathing and assessment of breathing so much easier. So I use Florence a lot in the hope that one day our lungs will be on the outside of the body. I was given quite a broad spectrum to talk about today, you know, respiratory medicine. It covers a multitude of things. And so I asked my medical colleagues that I work with what I should do, and they laughed and they said, you can't get that done in an hour. So I'm going to just share a few things with you, and I hope that's probably what you want. So this year we've had the changing face of our country, really. We've been met with this man, and if you don't know him, you've been living under a rock since about the middle of March, and the wee shot of our COVID virus. So really COVID's been in our face most of this year, really, and I'll talk a wee bit more about that later. But he has become the pin-up boy, and I had to sort of really include him in the slide because it's showing the map that the World Health Organization put out behind him, and it really is a worldwide cover that this COVID has caused for us. So I was thinking about COVID, and I thought there must be some good things that happened about COVID. And one of my colleagues come up with this how to wear a face mask idea. And I love the fact that the nurses in the middle amongst all the superheroes. So the way we breathe hasn't really changed during this process, but probably the attacks on the way we breathe has. And I think it's really shone the light on our infection prevention and control teams around the country and the use of PPE. We had this program of donning and doffing, and they were terms that I found quite hilarious every time I did it. And I've worked in the health organisations since the early 70s, and nobody had ever fitted a mask to my face before. So 40 something years of working, and I've finally had my mask fitted to my face. So donning and doffing was quite an experience, and certainly our medical staff had often never been shown how to put on PPE before. And I think the good thing, and I think the thing about that has come out of this is the team that we work with, not just the team of nurses and doctors and physios, but the orderlies, the people that deliver the meals, our cleaners. The team was the good thing about COVID, really, and it showed what a strong team we all have in this country. I think there's some bad things that happened around COVID as well, and certainly wearing a face mask for a very long period of time. There was loads of photos around social media about bruises and swellings and sort of the effects of wearing a face mask that is done. And of course we all know where Donald Trump should be putting his face mask, but there are probably the bad things that happened with that. One of my colleagues said that by the time they had donned all their protective equipment correctly, gloves, overshoes, hats, full face masks, they were sweating so profusely that they almost needed to go out of their PPE and get changed again. And we would have 2 people at a time in the COVID room as a minimum, and they would be, after after 3 or 4 hours they would have a break. But I think the bad thing was we didn't have enough PPE really. We had ample supply for what we had, but if we were to become overwhelmed with COVID patients, we are in isolation and intensive care, I think we would have run out of equipment quite quickly. We were lucky we only had one patient in the Dunedin ICU. I think another good thing was the sharing of information. We got a lot of information. This is showing one of the casts the World Health Organization put on their site, and it's from Italy, and they talked about their experience, and it is very interesting to read. And they said that they were prepared for COVID. You know, they'd talked about it, they'd prepared, they'd practiced, but they said unless they were in COVID, nobody actually understood what it was like. And they talked about the tsunami of the effects it had on them. It was like you were being overwhelmed by a massive tidal wave. And then redefining your hospital, like we have an ICU on the 5th floor and we can take 12 patients, but what happens when those 12 beds were full? We've got a post-anaesthetic care unit around the corner, so we would take over that. Then we would move into theatre, which is also on the same floor, and take over the day surgery unit. And I think for my mind, I couldn't actually imagine that happening in our country, but it did have to happen in other countries. We practiced our PPE, we practiced our intubation and how we would ventilate patients. Some of our medical staff come up with weird and wonderful ways to intubate within a closed circuit, and how we would give medications to a patient to anaesthetise them from a distance. And thankfully we didn't have to use that terribly often. Certainly from the work that I've read about from Italy, and certainly from the UK, not so much the USA, but it's about that being prepared and that early recognition, and that any time you are suspecting that a person's got a respiratory condition, almost treating as if it was COVID until treated otherwise. I don't know how many of you had the lovely opportunity of having a viral nasal swab done, other than the fact that I immediately wanted to sneeze. So everybody's in PPE and they're doing this, and you want to sneeze into your elbow, but they've still got that swab up your nose. My God, I'm sure they were tickling more than the back of my nasal pharynx. An extremely interesting experience, I have to say. But that early detection was able to, I think, prevent a lot of people deteriorating to the point they needed ICU. That early detection, the early fluids, and then managing with non-invasive ventilation, so high flow nasal prongs, some CPAP, and intubating if we needed to. They talk about lung ultrasound in Italy as one of their diagnostics, because it could be done at the bedside, so you really don't want to be taking the COVID patients through the hospital setting. And lung ultrasound was certainly used, and ECMO was the other alternative. Well, in New Zealand and Dunedin, we had the ability to put one patient on ECMO. Our country's not that large. We do most of our ECMO through Auckland, so if our ICUs were overwhelmed with ECMO patients, Auckland would be inundated, and it would only be the first probably 15 or 20 patients that would have got ECMO. So they were some of the things, and I found that sharing of information really good. Certainly even China put out, you know, try this mode of ventilation, it seems to work better. And there was a lot of sort of sharing of information in a nice way, not necessarily from the USA, but that's another matter. So we practiced our proning. So the class of smiling, happy people on one side of my slide is the class of critical care qualified students last year who were doing the critical care course, and of course they've all given me permission to use this slide. I actually forgotten to ask any of them, but I'm sure they won't mind, and they're practicing rolling their tutor into the prone position, and they're all laughing and joking, and little did they know several weeks later they would actually be doing it with full PPE on in hot, sweaty room with a very unwell patient. And the man at the bottom of the screen is a patient proned. He's lying face down, he's ventilated, he has got a multitude of infusions running to keep him asleep. And this was the way that the majority of the patients that have survived ICU in the prone position. He would be prone for up to 20 hours at a time, and then he would be turned again using 6 to 7 people to turn him. And then he would have a chest x-ray done and everything that you needed to do to him when he was on his back, and then you would prone him again. And certainly the patient that we had within the ICU was prone to quite a lot during her stay. So the ugly things that happened, I'm slightly immunocompromised, so I got sent home and I had to teach from home. Oh my God, I hated it. I did things like I forgot that I wasn't on mute, and I would have a conversation with my husband. He would say, would you like a coffee? And I'd get up and walk away, and I'd have a class full of 15 or 20 medical students I was supposed to be teaching, all patiently waiting for me to come back from the kitchen with my coffee. I hated teaching from home, and I'm very glad that they let me back during stage 3. So if I get locked down again, I'm going to have a large multitude of things to do other than teaching from home. And then the first day of lockdown was the day I was supposed to move my house. And that was probably the worst thing that could happen. We had 2 houses for COVID. One of our houses had all of our belongings in it, and the other had all our furniture in it. And we were locked down in the house with the furniture. So they were the ugly things that happened to me during COVID. What could have happened was this photo of an ICU in the UK, where they had 20 beds in their ICU, and their 20 beds were full within 6 days. This happens to be their day surgery unit, where they did tonsils and adenoid removal, and there's one huge room of ventilated, prone COVID patients. I think they said they could take up to 12 patients in one room. All of these patients would have 2 staff, and just keeping up the consumables and the cleaning and trying to keep your PPE on. We didn't have flash oversuits like they had. We had the good gloves, lovely yellow gowns, and our overshoes, headgear and face masks. So it would have been great if we had equipment like that, but we didn't. So we were very thankful in this country not to be swamped like they did in other areas. So what is breathing? I've had to talk about this, and it seems a very simplistic explanation of respiration. But if we don't get this right, all of the previous things that I've talked about will happen. So respiration is that exchange and transport of oxygen and CO2. We get oxygen from the atmosphere. We need that cell division, we need that ventilation at cellular level, and we need energy, and we want to avoid hypoxia. And I do like that t-shirt. I got that that's one of the good things I got from the States, showing the anatomy. I wore it to a medical school class once. Unfortunately, I had it on during an exam, and I found students were looking at me, and actually it's not anatomically correct, but it did show 3 lobes on one side and 2 on the other, so I think it was worth half a mark. So I must remember not to wear that shirt again. Just a wee reminder, we always think when we're thinking of our respiratory system that it's the lungs, but don't forget the diaphragm and the nose and the mouth, the entire track. We were doing some sim training today, and they were going through a sim where the patient had their jaw wired, and we needed to cut the wires in a hurry. Simple things like, we forget that if we haven't got a completely intact respiratory tree, any place in this incredible system of ours, we can fall down and have patients as sick as their COVID patients were. A reminder, there's probably some poor medical student who paid to have a chest drawn on the outside of his body, but it does remind us where our lungs sit, and the apex of our lungs above the clavicle, which I don't need to tell you about, but it is just a nice reminder, and the lobes at the side. And when I look at these, I can understand why we proned our patients. It was the basis of the patients that got sick, and I'm going to show you some x-rays soon, and when the patients are lying down, the posterior part of our lungs filled up with fluid, and we got severe severe atelectasis. So to prone them, we got our good lungs lying down, so we get better gas exchange. It's all about our alveoli, and I think there's not enough credit ever given to the alveoli. If we haven't got alveoli that will open and close and have a good capillary bed to allow our oxygen to go into our bloodstream, then we are going to be severely unwell and we'll end up quite hypoxic. And I think a thing to remember about normal breathing is quiet. So if you are sitting in a room and you can hear somebody breathing, there is something abnormal about that breathing. And I think it's a very simple thing, but if I go out into the wider hospital to see a patient or to assess somebody, and I'm in a 4-bedded room and I am often listening to the patient I'm there to see, but you can hear somebody else breathing. So there's something wrong with that respiratory pattern or that patient himself. So normal respiration should be quiet. So we all need all of these things to help us breathing. We need some sort of atmosphere, we need oxygen, and we need that intact brainstem. And our brainstem can be damaged from a multiple array of alcohol, various substances we take, swelling, edema, and blood loss. So our brainstem can be damaged quite severely. And if we don't have our brainstem intact, all our other systems regarding respiration will change. We need pressures, we need the atmospheric pressures, our interthoracic pressures, and our pressure, that potential pressure in our pleural space. Our baroreceptors tell us about when our CO2 is getting too high, and I see this in my medical students. I'll be sitting there and they'll go, oh, that's the baroreceptor saying, hey, your CO2 is getting too high, have a big yawn and blow some CO2 off. And they're in our chest and our brain. We need that whole intact respiratory tree right from our mouth down to our diaphragm. We need lungs that are intact. They haven't been damaged by cigarette smoke, by atmospheric pollutions, and that are intact without holes. And we need those lovely alveoli that I talked about before. If when I'm doing this talk normally, I get the people to work out these themselves and to talk about these, everybody forgets the heart and the respiratory system. And I know I find it quite hard not to teach heart, cardiac and pulmonary together, because if we don't have a heart pumping our red blood cells, then we have lost our oxygen carrying capabilities already. And it doesn't matter how perfectly we're breathing, if our heart is not pumping and we haven't got enough red cells, we are going to get severely hypoxic. So red blood cells come into that as well. And our pleural space I've talked about, we need muscles and we need some nerves. So all of these happen independently to us thinking, I must breathe in and I must breathe out. We can, it's one of the systems we can change. We can make ourselves breathe faster and we can hold our breath. But certainly we can't do that for a long period of time, otherwise our body will tell us we need to correct it. I had a very learned doctor that precepted me when I was learning about health assessment, and he lived with me forever, that he told me that taking an accurate history of what has happened to your patient and actually listening to that and putting it all together gives you almost an 80% diagnosis of what's wrong with that person. And when you watch a really skilled practitioner taking a history from a patient, you know, sometimes it feels like getting blood out of a stone, but you know, they are picking up on clues from the patient. They're asking really relevant questions, and they're asking, you know, what's changed for them. And often what the patient's complaining about is not always what is wrong with them, but it gives that feeling that the practitioner is listening to them and they will want to share more. So if you take a really accurate history, a full history, you've probably got 80% of your diagnosis already. So there's a few things that make my heart beat faster, and I have been in practice for quite a few years, and they change from time to time. And I wander around the hospital with my stethoscope and my neurotorch, and that's probably the only things I take. And people say, oh, but you work in ICU, you've got all these flash equipment and la la la, but I take my stethoscope and my neurotorch with me. So if I see a patient that's not breathing, you know, I want to potentially know why they're not breathing, and there's something we can do about that quite quickly. We can use an ambu bag and we can help ventilate them. We may have to do other things for them, but it's quite surprising walking around a hospital or seeing patients in a clinic, and you're walking through a clinic room and you think, gosh, I hope he's next because he really doesn't look well. Where actually the man next door might look really well and have a respiratory rate of 4. Not good. If I hear a stridor, I worked in paediatrics as a charge nurse for about 10 years, and that ear pitching stridor that used to get when children had a swelling in the airway, I think it stays with you for a very long time. And anyone that's got an increased work of breathing, I want to know why they've got an increased work of breathing and is there anything I can do about it. Unequal chest movement often in my world means a pneumothorax. And any swelling around the neck and the face, doesn't care what caused it. I want to know about that too. And then I've got 2 categories. I've got the pale, grey, cold and clammy man. And then I've got the very flushed and sweaty and very hot and wet man. And they're both extremes of the same continuum, really. And if I'm auscultating a chest and I can't hear anything at all, a very silent chest, that's a worry. I love looking at sputum. Any people that know me will say I'm fixated on sputum, and I'll talk about sputum a wee bit longer because I do quite like it. But if there's blood in the sputum, that's one of those red flags I don't like to see. And I hate it when patients can't respond to me. Now, I work a lot with tracheostomy patients, and people say, oh, but they can't talk, but they can still respond to you non-verbally, and you get lots of hand gestures from trachea patients, and you know exactly what they are meaning by that. But the ones that don't respond to you, there is quite a worry about that. And certainly the child that's not speaking or engaging with their surroundings or toys or their family, or isn't even crying, is a worry for me. So there's some allergies that flick into mind as well. This person here has got, I don't know if you see my cursor moving on the screen, but there's a great big lovely something there. Now this person takes really good care of their teeth. They've got some implants done. There's no other fillings in their mouth. You can tell that I'm married to a dentist. Very nicely trimmed moustache. And what's all this fluffy stuff down here? Well, it's under the allergy screen, so it should be giving you a hint. This person has a reaction to bee stings and was riding a motorbike, and a bee flew into his helmet, and so he just kept driving to the hospital where they gave him an EpiPen and got his treatment started. But it's a great photo of pulmonary edema. So this very sparkly pink frothy stuff coming up from his throat, his pulmonary edema. So he'd probably sound sort of that sort of noise when he was breathing, but good on them. They made him open his mouth so they could get a photo. They know me very well, thankfully. So bee stings are certainly people with angioedema. So there's a whole lot of people in our community that have allergies to food, to pollutants, to lots of substances, and they may get angioedema, a stridor, and the same thing like in this picture. Smoke inhalation, when you've got a fireman that may have been in a fire and there's a history that his helmet's cracked or his visor's cracked, and he comes in with soot around his nostrils, and he's fine, he's walking around, he's saturating fine, but if there's any sign of soot, he will go on to some high flow oxygen and will stay in the emergency department for at least 4 hours to make sure that he hasn't got inhalation injuries from the smoke. And our near drowning patients, now we recently had a patient who took his grandchildren to our Moana pool, which is the public pool in Dunedin, and it must have been about February, and he was in the pool with his grandchildren, and the grandchildren said, oh, granddad's floating on the bottom, and he had probably an MI in the pool, and he had lovely clean water that children have been swimming in and not urinating in, and lots of chlorine in his lungs. So his whole lungs were filled with the Moana pool. So not just clean water were in his lungs, but all the trace elements that were also being absorbed as well. He did make a full recovery, but I think we forget about the near drowning person with whatever's in the water now in their lungs. So I like this photo of an elephant because I look at it and I see, some days I see 4 legs, some days I see 5 legs. And if I'm really tired, people can actually convince me I can see 6 legs sometimes. And, you know, and we all know in our minds that elephants have 4 legs, but if your learned colleague comes along and you're feeling a bit frail and you're at the end of a long shift, they'll say, no, there's 6 legs there, Linda. And often we change our mind, and it's a bit like you've done a great respiratory assessment of your patient and you've found all this fabulous information, and somebody comes along and says, no, that's not right. And as nurses, sometimes we back off and say, okay, I agree with you, when actually we're right all along. So we know that elephants have got 4 legs, and if you have found 5 legs, you own the 5 legs on the elephant, because who's not to say that the next time somebody looks at the elephant, there will be 5 legs there. That purposeful look is really important. It buys you some time sometimes. You know, I go along to see a patient and I can hear them breathing from the end of the corridor, and there's the crash trolley sitting outside the room. That's always a bad sign. And you go in and you think, oh, standing at the door and gelling your hands is amazing, because it buys you some time. It gives you the chance to observe the patient from a distance and inspect the things that you want to see. It's like that. I'm looking for things that I can correct now. I like to go in and I like to extend my hand and shake hands with my patients, and even currently with COVID, I still do that, because you feel how warm the patient is, how well perfused their skin is, what their capillary refill is. Are their hands sweaty? Are they damp? Have they got a tremor? All of those things you can find in a handshake. And if you're really smart, you can feel their pulse at the same time. And patients go, oh, isn't she lovely? She comes in and holds hands with me. Well, no, I'm actually starting my assessment already. I'm not that nice. But it's that, be purposeful. And what else can you see? You know, how many inhalers are sitting behind the person? What's their oxygen up at? How many pillows have they got stacked on their bed? What colour is their sputum in that little tissue sitting on their table? You know, open it and have a look, have a sniff, all of those things. That purposeful look is incredibly important, I think, for an acute respiratory deterioration, as well as the chronic patients that we see with chronic conditions like COPD. Some things are really obvious, you know. I took our healthcare assistant who works alongside us, her and I were going for lunch one day, and we were going for lunch at like 3:30 in the afternoon. We'd had a horrible day, and we're thinking, oh, the hospital aide always knows what's in the cafeteria for lunch, and it was her favourite. And we got out of the lift on the ground floor, and somebody collapsed in front of us, and I went, oh. And Jean said, it's mac and cheese day today. And I said, oh, we better stop and do something about it. But we actually, for a split second, we were just going to step over him. And no, we did stop, and we got him appropriate help, and he went off to the emergency department, and there was no mac and cheese left for Jean, so she was not happy. Some things are obvious, like, does this man have a respiratory issue? Possibly not. He could have a mental health problem. I hope he hasn't got a coagulation disorder. But I think sometimes when we look at things, we make that, is it this an emergency, or can I spend more time getting this right? How do I get help? Now, I'm not going to tell you how to get help, because all your practices are different and your ways of getting help are completely different to mine. And sometimes you just want to go and have a cup of tea and think about it before you get going, but actually you can't. You can't step over the patient in the foyer. Unfortunately. So this was one of my earlier photos of a retrieval when the Dunedin flight team wore bright yellow banana suits. I was sucked into the explanation that we wore yellow suits, so if we ever crashed at sea, they'd be able to find our bodies. But actually, in fact, it was because it was the cheapest fabric they could find for us, and it was a bulk order. Thankfully, these suits were phased out in the 90s, and we got lovely black ones now with our flight team on the back of them. But yellow suits, we looked like big Teletubbies. It was just disgusting. So I'm a nice, clean ICU nurse. I like to live in a nice, clean hospital. And I was flying to one of our rural practices one day, and we got diverted to a dirty road scene. So I wanted to stay in the helicopter, but they wouldn't let me. So the doctor I was with got out because he's a good guy, and we were met with this car. So the first idea is this: they're cutting the roof off the car, it's been rear-ended from the back and hit from the front, so we're all thinking this person's going to have multiple injuries. Could have head injuries, could have steering wheel to the chest injuries, pneumothoraxes. All these things were going through my mind, and I'm thinking I'm going to get dirty and I'll have to do something. But once they got the roof off the car, they found all this man had was a broken arm. And he was very, very lucky, but we didn't know that until we'd gone in and assessed what the person did and knew the history of what was happening. So respiratory assessment, review the systems. If it's a chronic patient that you're seeing and you've seen that person lots of times, I'll often start with how's your general health. I see tracheostomy patients in a clinic with the speech and language therapist, and we always ask about what their appetite's like and if they've had any weight gain or lost, because it's not always easy to be getting good nutrition if they may be peg fed or nasogastrically fed, but often a lot of them are actually eating. What's their sleeping patterns like? They're using lots of pillows at night to help them, prop them up. Is their mood changed? Do they have any new pets at home? Have they got any new hobbies? Now, my husband retired a few years ago, and he decided he wanted to put together model aeroplanes because he liked flying and various other bits and pieces. I got home from work one day to find the whole house full of glue, that lovely, really smelly glue that, glue sniffers sniff. My husband was as high as a kite. He, bless his heart, he's not like that ordinary often, but he was as high as a kite. And I said, what are you doing? And he sat there and giggled for about 20 minutes. So I opened all the windows and doors, took the glue away from him, and he was making these airplanes in a confined space with no ventilation, hadn't read the labels, wasn't wearing a mask, all of those things, and he was as high as a kite. The next day, he had a sore chest, he couldn't take a breath in, and I said, you go to our GP and say, I've been sniffing glue, and see what he says. So I think you've got to ask about hobbies and pets. And exercise tolerance is hugely important. And I had a patient not long ago who said, look, I walk the length of George Street every second day, and he looked like a man that wouldn't be able to walk the length of George Street, which is our main street in Dunedin. And I said, look, how far do you walk? And he said, I walk from bus stop to bus stop, and I have to have a 20-minute rest before I carry on, and then I get the bus home. So I hadn't asked the question the right way. So that review of systems for the patient, you will often get gems of information that are going to lead you in your physical assessment of the patient. And if you follow that same format, what can I see, what can I feel, what can I percuss, and what can I hear and auscultate, you won't miss anything. So inspection starts when you first meet them. I love Australia. I love going diving and I like swimming, and I really like the fact that they gave me this slide because I use it all the time. So, if there's a dressing, you've got to sniff it. If there's something covering up, you've got to look at it. I love looking at sputum. Sputum's wonderful. It tells you how how hydrated your patient is. Is it sticky like chewing gum? Is it sticking to the sole of your feet? What colour is it? Is it green? Is it brown? What, has it got flecks of blood in it? Does it smell of Pseudomonas? Now, those sort of things stay with you. If you've ever smelt Pseudomonas, you can pick it a mile away. So use your senses when you are dealing with a respiratory patient, and be really particular about looking at their sputum. How much sputum are they producing? My trachea patients know exactly how many times they suction them. They know exactly how much sputum they're getting up. The COPD patients know every time they cough, it's a tablespoon or half a tablespoon in the colour. I bet every time you cough, you look at your own sputum to see if there's any blood in it and cough. It's like when you pee, you always look in the toilet to see what colour it is and how much you've gone, and sputum's the same. And that inspection starts when you first see the person. I've got another photo here. So if we're going to inspect this man's chest, the first thing I want to say is what a fabulously sleeked chest drain that is on that side. What a magnificent job that nurse must have done sleeking that chest drain in. And when I showed my colleagues, they said, oh my God, you even sleeked his nipple. But that chest drain was not going to fall out of this patient in the helicopter flying back to Dunedin Hospital with me beside him. So when I look at this chest, I hope you notice things. He's got a collar on. He's got ECG dots on, so, he's being monitored. And obviously there's that big obvious thing on this side of his chest. And if I was to tell you this man hadn't been in a car accident, he'd only injured his chest, but the paramedics still put a collar on him as part of their protocol. He'd been in a pen with a horse, and he was cleaning the horse's hooves, and he dropped his scaling instrument, whatever it was, and the horse kicked him repeatedly in the chest. So he had a hemopneumothorax on this side, but that wasn't what made us bring him back from Central Otago. It was this very great large area here. So yes, we have our lungs under here, and yes, there could have been lung contusions, but we actually brought him back to Dunedin because he had cardiac arrhythmias. He was getting ECG changes and loads of ectopics and multifocal ectopics, and we were concerned that he could have had some kind of cardiac contusion as well. So just inspecting a chest, I can't get that chest to rise and fall for you, but you can gather a lot of information by just looking and knowing the history of the injury. So what about this patient? You look at this patient and you see, he's got oxygen on sort of in his nostril. He may only have one prong on there, but he's got oxygen on. He's looking a bit grey. Might have a bit of pursed lip breathing there going on, but it looks like he's at the gym. Like that looks like it's one of those cross trainers behind him. And what is he doing? But he does look like he's wearing pajamas, so it might be the physio gym. So you can glean a lot by just looking at that gentleman there. I'd like to look at his hands, and I'd like to look at his fingernails and see if he's got clubbing and what colour they are and his capillary refill. I'd certainly like to look at for any nicotine stains that he's got on, but he does look like he's a wee bit undernourished as well. And I'm just implying that I don't know this patient. I got this photo off the net. So inspections, all of those things we talked about. One of my colleagues works in mental health, and she isn't able to touch her patients. Some of her patients have this bubble around them, if you like, where they don't like you to invade their space. So she has to do a lot of her physical assessment of her patient by just inspecting. And she will often say, how are they dressed? Are they dressed appropriately? Is it a freezing cold southerly blowing in Dunedin and there's ice on the ground and they wear shorts and a singlet? That is often the first indication that there is something wrong, that they a lot. And then the next thing they'll look at is their respiratory rate, and are they speaking in sentences, and the things that we look at all the time. But I certainly do like to look at their hands, and maybe you'll have to get that person to turn their hands over for you if you're not able to touch them. Skin's a great thing. You've got the patient's date of birth in front of you and you think, oh my God, she's only 30 and she looks 110, has she had a good life? You know, she looks like she's been baked by the sun. Her hair, even though she's wearing her wee tiara, her hair looks like it's been damaged by a lot of sun as well. So if she looks like that on the outside, she looks like that on the inside. You know, I love cardiothoracic surgeons. They say, oh, we've got a very crisp 88-year-old today. You're 88 years old on the inside as well, so I just don't understand that. But your skin's a dead giveaway, you know, especially the skin around your neck and on your hands. So look at skin. Is it well hydrated? What the skin turgor is? Are there any blemishes? It does give you an idea of the general well-being of your patient. Another one of my favourite patients. So a general inspection to start with, there is a lot of blood. But we know that a little bit of blood does go a long way when there's something bleeding. The other thing I noticed about this, the doctor in the emergency department has got his watch on. Really, you know, times of PPE, you know, and our use of it, and he's got his watch on. But really, this man's not being monitored terribly well. He's got a saturation probe on, the blood pressure cuff. And if I was to tell you that this happened on the 5th of November, you might think it could be fireworks. And what happened is this man is well known in Dunedin, and I was asked to fly him to the burns unit and to Burwood Hospital, the plastic surgery unit in the South Island. He, very intelligent man, he put he was trying to light the firecrackers for his children. It was windy. So for some odd reason, he put them in his mouth, covered the crackers with one hand and lit them, and he blew off the end of his tongue, some of his teeth and a bit of his lip, and scorched the top of his head with a flash burn. So he was going to Burwood for some construction surgery. He knew me quite well, and he said I could use that photo as long as I never told anybody how he did it. So I've never done that since. But really, at first impressions of this guy, you would think it was something really horrendous, and for him it really was. He had made a mess of his teeth, but a little bit of blood does go a long way. That inspection we've talked about already. I've got another chest here. There's one side's got pathology in this chest. When you're looking at this chest, you can't see it rising and falling, but there are some hints. The clavicle on this side's higher than the clavicle on that side, and the shoulder is coming down more. And if you were to be watching him moving, this side of the chest is not moving, this side is, and he's had a spontaneous pneumothorax. And just standing at the end of the bed, there was no need to go and get an x-ray. This boy had had a spontaneous pneumothorax before, after sport, and it was always that drop in his shoulder, and the giveaway was only one side of his chest is rising and falling. Oral in the mouth, like I do get fixated about teeth, but I always get people to open their mouth, let me see their dentition, how clean is it, because that does reflect on where does all the bugs drain. You know, we've got our lymphatic system that drains, so does that go down into your chest? What's their heart like? How are their heart valves? All of that. There's bits of chips off these teeth. Are they in the lung? Are they not in the lung? Where have they gone? And you know, get used to looking in people's mouths as well. Palpation, feel the chest. Is your chest expansion equal when you're taking breaths in? This person here has got a very large mass on the side of their neck, and it's really, really convenient. They've actually got a felt pen where the trachea should be. With all our patients would come with it drawn on the outside, but this person's actually got a deviated trachea from a very large goiter, and it was clearly it was a chronic thing. It hadn't happened really quickly, but this is one of the first tracheas not in the midline that I had seen for many, many years. So feel the whole chest. Is there any pain? Does the patient feel pain anywhere? Is there any tenderness on palpation? Can you feel that tactile fremitus that we should feel up here but shouldn't feel at the bases of our lungs? Percussion's a great skill to use. I percuss my patients all the time when I see them. It saves them needing to have regular chest x-ray. It's a skill you have to practice in percussion, and you get really good at doing it. So if you do percuss, well done. If you don't percuss, you know, get hold of somebody who does, you know, marry up with the local GP or the physio who percusses all the time and get used to doing it, because it's a really good tool to have in your toolbox, especially if you haven't got ability to x-ray all the time. Auscultation, I think you've got to know what normal sounds like before you can listen for abnormal. And if you're listening to chests 1 hour and you go back and listen again and there's been a change, well, it's good that you've picked up on it. You know, it's just getting used to hearing wheezes and crackles and what rubs sound like and what sounds sound like in the chest. And there are things that you need to listen to and practice. And when we're not hearing sounds, what does that mean? Is the air in the chest, is the fluid in the chest, or is something thickened, or if part of the lungs actually got reduced airflow from other reasons? Look at trends. You can't just look at one number. Oh my God, he's got saturations of 88. So what? He might normally have saturations of 88. It depends if he, last hour, had saturations of 100. It's looking at that trend and over a period of time. Certainly look at sputum. The sputum might look really brown or dirty to you. Ask the patient, is this good for you or is it not good for you? And certainly that degree of anxiety always happens when certainly our long-term patients start deteriorating, and that was one thing that everybody talked about in COVID, when patients were coming in with very low oxygen saturations and very low oxygen in their blood. They all had that degree of anxiety and fear. Now, was it because they were hypoxic, or was it because they thought, oh my God, I've got COVID, I'm going to be one of the national numbers? And it was hard to pick. But we do know that some of our long-term patients, our COPD patients, will have that fear and anxiety, and that may be that their hypoxemia is worsening. Presenting common complaints that we see all the time in respiratory, they haven't changed. But remember, not all chest pain is cardiac. It may be respiratory. It can be from that pleuritic pain. A lot of, when we had SARS, you know, I've been around a long time. I've been through the bird flu, the swine flu, all those flus. The SARS patients often come in with chest pain. They often come in rubbing their chest centrally, saying, I've got chest pain. And actually it was pleuritic pain they were having. Somebody that's restless, tachypneic, confused, anxious, irritable, and they weren't before. So something has changed for them. Anyone that is short of breath or finding it difficult to breathe and saying, breathing is hard for me. And we talk about breathlessness as well as being a new almost chapter in our respiratory manuals as a new disease. Along with the respiratory signs will come patients that are hypertensive and tachycardic and are diaphoretic for whatever reason. They may not have a fever. They may have crackles. They may have abnormal sounds for them. They may have a cough. Now, I looked up cough in a textbook a wee while ago, and it's one of my favourite textbooks, and there's 45 pages written about cough and describing a cough. Is this your normal cough? I often ask patients. Is it, you know, dry? Is it moist? Is it wet? Do you want to be sick when you cough? All of those things will come into asking about a cough, and I won't talk about sputum anymore. But changes in level of consciousness are normally meaning that this chronic patient's CO2 is rising, or the non-chronic acute patient is becoming more hypoxemic. Things happen when we get older, and you know, life's a bitch when you get old. And when I was reading about aging, I was thinking, oh, I've had knee replacements done and I love it. You know, I love my knee replacements. But when I think about breathing, your capacity for exercise decreases. So that's a really good reason for not walking up the stairs. But your chest wall becomes stiffer and it becomes harder for you to move your chest wall in and out, and your respiratory muscles lose their ability to recoil, so the ability to take a big breath in if they get a fright or have that big reserve, and they lose their elasticity. And it's like when your knickers go all saggy and you've got those saggy elastic in your knickers. That's what your lungs happen when you start getting older. Your FEV1 becomes reduced, your ability to be able to breathe out quickly changes. And you get some skeletal changes as well, so the structure of your chest to support your respiratory system will go. And I put pregnancy in there. That's not an old age person's thing, that's a new, younger, much younger people. But if you've got multiple babies inside a very small abdomen pressing on the diaphragm, it makes it really, really hard to take a big breath out. I was helping with a lovely lady the other day who had 3 babies in her diaphragm, and she was under her diaphragm, and she is 5'1", and her babies are all good sized babies, but she just can't take a big breath in, and we were getting a little machine to help her with some IPAP to get her over sort of some stress she was having about her breathing. So in my world, I think this year things that have happened, we've had really, with COVID, we got some more money. So we got really good ventilators. We've got ventilators now that can really synchronise with patients' ability to breathe. We got much, much better BiPAP machines and CPAP machines and some high flow machines that are all come in the one machine, which is really good. Early tracheostomies for head injured patients or for patients that have had trauma where you want them to have lots of PEEP was another thing. We didn't go down the early tracheostomies with COVID patients because it was going to be probably having that aerosol infection in the room would have been horrendous for a tracheostomy to actually perform the tracheostomy. So COVID patients that have been tracheed were tracheed 3 or 4 weeks down the track when they had the multi-organ failure that went along with it, as opposed to the COVID which is causing it. And the ability to see a lot of people in clinics now, it has been fun doing some virtual clinics with people, but most of my patients have tracheostomies, so it's hard to sort of talk to them, but we having clinics with multidisciplinary team like the speech and language therapist and the dietitian, we have great fun. And we had a man who self-referred to us the other day, and he travelled 4 hours to see us. And I said, oh, look, I thought he was doing really well. And so he arrived and he wanted the last appointment for the day. And he arrived in looking the most robustly healthy person I've ever seen. And he had a bottle of wine and a bunch of flowers for us all. And he had made an appointment because we're such busy people and we've got no time to see him outside of that. So he made an appointment just to bring us some wine and some flowers. So that was really good. So I think the positive things in my world at the moment. So I don't want to go over time, but I thought I'd share some COVID x-rays with you. And I think if you're not used to looking at x-rays, just remember air is black, and having really black x-rays means you've got really healthy lungs. So here is a photo of a normal x-ray, a normal healthy person, and here's a photo of a COVID patient. You can see the only really black bits in this lung are right at the apex and probably on the posterior of the apex. And all this is fluff, looks like pneumonia. And the way they would say, well, is this pneumonia or not? The only way they could do it is to do the viral swab testing and wait for it to come back. But he would be treated as a COVID patient until otherwise. Here's another x-ray. And this person is 41 years old, and this person had a fever and a cough, and that was their initial x-ray. And this is a 3-dimensional CT scan that they used to get the photo of the COVID. So these areas here where the arrows are all really dense. They call them ground glass opacities, and none of these really white areas here, none of that will be involved with gas exchange. So you're not going to be able to get oxygen in, you're not going to be able to get CO2 out. And basically this infiltrates all the way down here and all the way up here. So very little lung volume is left for expansion. And here's another picture as well. This is a digital one where they've removed everything. It's a normal lung on this side. You can see the vasculature and right down to the diaphragm. So this is the COVID lung. There is not much lung left in that. You've probably got a little bit on the apex as well, and the posterior side of the lungs at the back you can still see some air in. And this is the reason we prone people. We put the good lung down so that the rubbish, if you like, is elevated. Gravity will help a wee bit, and we'll get better perfusion. Well, that's what we thought. And certainly the patient that we had in our unit arrived to us with very low oxygen in her blood and very low saturations, we were lucky to get her saturations in the 80s, even on full mechanical ventilation, and she only would improve slowly if we had her proned. We hint about pediatrics. I am a pediatric nurse. Don't treat children like they're small adults. When they get respiratory distress, they don't complain like we do. They get quiet and floppy, and they get their nasal flaring. They want to sit on mum's knee. They become quiet and quiet and not want to engage with the surroundings. And the child that becomes floppy is really a medical emergency, and they become like that. And really, our stats are like the rest of the world. 50% of pediatric emergencies result from respiratory distress, whether it's asthma, bronchiolitis, croup, or an obstructed airway. The airways are small, they're underdeveloped, the supporting structures and cartilages are very soft and pliable, they're easily compromised. The trachea is about the size of their little finger, so any bit of mucus or wheel of a car, toy, or anything that gets blocked in their airway will compromise their respiratory state, and they become hypoxic very quickly. They have a large tongue in proportion to their mouth, and it will block their airways as well. They've got a very compliant chest wall, so they're always damaged from non-accidental injuries like squeezing and shaking and trauma as such. And I found this photo many years ago, and it stayed with me as a reminder of what a very unwell, pale, sick, frightened, scared looking child looks like, and that those sort of things will stay with you. So in summary, I just want to say the respiratory is a huge topic, and you could talk about it for hours, and I probably could, but I won't. But remember, it's about ventilation. So with COVID, we couldn't ventilate people. Because we couldn't ventilate them, we couldn't give them oxygen. Their lungs were full of something else. And because we can't get oxygen in, we can't get that CO2 out. And they become very unwell. But that purposeful look at the patient, and don't miss is the chest rising and falling. They're really good things to remember. The rate of their respiratory rate. Their respiratory rate is the rate that's going to help try to get our acid base back in and our hydrogen ions back in. And if they're breathing really fast, they're working really hard, they're going to go from type 1 to type 2 respiratory failure really quickly. Have they got a cough and a gag? That's always quite useful to know. Feel their chest, percuss their chest, auscultate their chest, and don't forget to look at their sputum. Use your senses. You've got hands, you've got ears, you can smell things, but just don't taste anything, because I'll get into real trouble if you start tasting sputum. So I hope you've learned something from this session. I can ramble on forever about respiratory. I hope I've touched on some things that you wanted to hear about tonight. I'm sure, I don't know, do we have time for some questions, Catherine?
Yes, we do have time for a couple of questions. Thank you very much, Linda. I am very entertaining and very interesting to listen to. Every time I look at a sputum, I'll be holding it up and thinking of you.
Stick it on your shoe and see if your shoe sticks to the floor. That person's dehydrated if they are.
Oh, and even their teeth, I'll have to start remembering looking at their teeth. And
absolutely.
Funny how you like to check them when you married a dentist.
It's terrible. It's just terrible.
And so somebody's come on and they've asked, what is the significance of hyperinflated lungs?
Hyperinflated lungs?
Yes.
If the person's a chronic patient, hyperinflated lungs in fit, healthy, well people shouldn't really happen. But with our COPD patients, our patients are used to, we breathe in, takes us 1 second to breathe in, seconds to breathe out, they have some restrictive ability to move their lungs in and out. So over time, their lung shape will start changing. They get that barrel looking chest, and that is, you know, they're breathing in and then they breathe out. And if they do that over and over again over a period of time, their chest will hyperinflate. Their lungs begin to look longer. Their spaces between their ribs look like they're opening, and that barrel chestedness will change. Unfortunately, bigger lungs don't necessarily mean better lungs, and it just means that their lungs, they've lost their elastic recoil, probably because often our COPD patients have been smokers or emphysema patients, and they've lost that elastic recoil. Their lung tissue themselves have been damaged, and it's a chronic thing. It's been a hyperinflation. If we have a hyperinflated chest in a younger person with no underground pathology, there'll be a reason to investigate that. That shouldn't normally happen. If that happens acutely, it might mean there's a tension pneumothorax on one side of the lung, but there should be some degree of history, and that would be that the air's coming in on one side and it's not escaping, so the other lung is becoming hyperinflated and eventually push across, and it's an emergency. But we don't normally see hyperinflated lungs in patients without pathology.
Thank you. Can the lungs recover after COVID infection?
Oh, I think certainly that's a $1 million question. I think certainly from people that I have met that didn't come to the ICU but had COVID at home and stayed at home and isolated and got over it. I met a girl the other day that had a month before she felt like she was human again, and she still is short of breath. Is she going to recover? Hopefully. Patients that have been in ICU have had a very high mortality. Our patient that we had unfortunately did pass away from multi-organ failure because of hypoxia and poor perfusion. But certainly there's been some success, but will they recover? We hope. Patients will recover. With SARS, which, SARS and MERS both belong to the same family as COVID, or COVID belongs to their family, I should say. There was about 50% of those patients had some ongoing respiratory problem if they recovered. And I don't think there's any evidence, certainly the evidence coming out of countries like Italy and Spain, there has been no evidence to say that it's going to be anything other than that as well. It's a $1 million question, that one.
And other than that, just messages of thanks starting to come in, just people find really informative, liked your sense of humour. Learned a lot from it, and thank you for sharing your time with us. Just to acknowledge that Linda's actually at the end of a 12-hour shift today to do this presentation for us, so we are very privileged that she stayed at work tonight to do this before she goes on to do her other job tomorrow, where she gets to run round in a nightdress and Ted stockings. But that's another story.
Yeah, that's another one. Yeah, I hope there's no new grads out there that are going to be in my class tomorrow.
But no, thank you very much, Linda. It's been great having you this evening. And yes, I'm sure we're all taking away some gems from your presentation. Getting the basics right helps build the whole lot, really.
Yeah, and it's, thank you guys for listening, because it's hard to fit a couple of hours in your really busy schedules for your own education. And so well done, you too. Good.
Thank you.